Welcome to the Thinking in Between podcast, which explores the borderlands between health and social science. In each episode, we meet with researchers working in this space to hear about the big ideas that have most influenced their research and thinking. But today, I'm really happy to welcome 4 ethnographers working in healthcare for a special episode thinking about ethics and ethnography. And I'm not going to try and introduce all 4 of them myself. I'm going to ask them to introduce themselves one at a time, saying who they are, where they're from, and also a bit about why ethnography in health research is so valuable. So, Kathy, can I start with you?
Thank you. So I'm Catherine Pope and I'm at the University of Oxford and I'm a medical sociologist. And I think I am an accidental but instinctive ethnographer, and the power of ethnography really came alive for me on my very first study, my very first job. So in 1988, I was working in a district health authority doing analysis of their hospital inpatient waiting lists. And I did all the things that I've been trained to do at university. I did, trend analysis of the waiting lists and pie charts showing the different kinds of patients that were waiting. I showed variation between the surgeons and all of this stuff. And then for some reason, I just thought, I don't really understand how patients get put on these waiting lists. I don't really understand how they're made. And that felt like a really good question to ask. And so I took myself off to the secretary's office where the list was made because surgeons came in and said, I'd like to put, Stephen Hibbs on the list for next Thursday, or I've just seen this lovely professor, Nicola Mackintosh. I'd like her to be squeezed in because, she's terribly important or whatever, and I watched all of this unfold, and I watched the way that they navigated what was a dual card and new computer system. And it blew my mind. I loved it. I sat there and I wrote pages of notes, and I'd been reading, Irving Goffman and all those sort of lovely, juicy ethnographies of urban life and healthcare settings as part of my undergrad studies, and it just really brought it to life. And I haven't really looked back since then, because every research question that I ask or that someone brings to me, I often think, but if I just went and looked at how it gets made or what really goes on, I'd get a better feel for it than just asking people. Because I find sometimes when you ask people, they give you, especially in healthcare, they often give you like the corporate account. They sort of say, well, I'm meant to tell you it works like this. So the managers in that hospital thought that the waiting list worked like a bus queue, that the people at the front got on the bus first. And I discovered it worked more like a supermarket, that people came in and lifted things off of the shelves as they fancied, and that disrupted the queue. And there was no other way of finding that out than by sitting there and watching what was going on. So that was my conversion moment.
That's beautiful. Okay, brilliant. Nikki.
So hi everyone, I'm Nicola Mackintosh. I'm Professor of Social Science Applied to Health at the University of Leicester. I think similar to Kathy, I think I had experience of other forms of research, and then actually I guess my first foray into what I felt was meaningful ethnography was during my PhD, and I was looking at how escalation of care was managed on hospital wards. And I think for me, it was just such a powerful way of understanding complexity and how that plays out in sort of everyday organisation and delivery of healthcare. And I love the way it shifts the lens from individual behaviours to collective practices, but also those wider influences at cultural, professional, organisational level. And I think certainly in my work, just sort of situating myself and following people, but also just watching, it was really, I think for me, quite powerful, making the mundane interesting. So what we see as mundane is often very different to others. And similarly, what healthcare professionals see as just everyday practice, we can, in a way, complexify that and think what's going on. So I think in that work, I was able to see what stays under the radar, what people don't take notice of, but what is taken account of and what is under scrutiny, and how some of the work that's done isn't really even accounted for. And I think that's really interesting from a political perspective of what goes behind that, and thinking about the institutional practices that shape that. And I think one of the really interesting concepts that I sort of thought about a lot during that work is that everyday medical practice is often about selling patients, actually making them interesting to others. And you wouldn't have got that in an interview. You had to be part of watching those referral processes to really understand the significance of it.
Brilliant. Thank you. Shadreck, can I come to you next?
Hi, my name is Shadreck Mwale. I'm an associate professor of Health Inequalities, University of West London. I work in the Geller Institute of Aging and Memory. Now, our work here is mostly around dementia care and improving care for people living with dementia. Most of our ethnographic work involves observing everyday hospital care, but also more recently, a study that I've just only started is looking at health and social care settings, looking at delivery or provision of care in social care settings. How does ethnography come alive to me? I don't have a fancy story like Kathy's and Nikki's, but I think there are quite similarities in what they're saying with what I find in my work. It's about there are things that you can't get any other way but by being present in places, in terms of understanding how people living with dementia, for example, make sense or experience being in a hospital ward. You can hear all kinds of stories, but it's not until you spend 4 hours on a ward observing what's happening in that particular space, looking at staff experiences and looking at people's experiences and conversations, and what Nikki refers to as the mundane, the things that most of the healthcare staff would not actually think of as either exciting or funny or of use, to us as sociologists actually become really useful. And again, Nikki has pointed to this about cultures of practice. There's no any other way you're going to understand how institutional cultures, I think, in my view, comes into place or becomes everyday practice, but by observing, including whether it's the administration of medication, whether it's supporting people with continence care, or whether it's supporting people with managing visitors onto the ward, and the pressures that all these things actually have on both the patients on the ward, but also for staff themselves. And so it's in these spaces that actually, for me, ethnography becomes a significant way and an important part. I can argue that it's indispensable, really, to understanding everyday healthcare. If we only relied on interviews, I mean, the amount of official accounts we hear, sometimes, which are completely different to what happens in practice, can be quite, surprising sometimes.
Thank you so much. And Fawn, finally, can I come to you?
Of course you can. So my name's Fawn Harrad-Hyde. I'm a postdoctoral research associate at the University of Leicester. I work very closely with Loros Hospice, which is our hospice for Leicester, Leicestershire and Rutland. My research tends to focus around care homes rather than health care settings as such, so perhaps what might be thought of more as social care settings. And I'm particularly interested in how people make decisions about what to do when residents experience deteriorations in their health. So should you call 111, 999? Should we transfer people to hospital? And my PhD work was an ethnographic study that was trying to get at some of these issues. I would agree very much with lots of things that people have already said. So I'd scribbled down some thoughts in response to your question, and I'd written things about sort of going beyond interview data and looking at sort of taken for granted aspects of health and social care, particularly if you're interested in the work of staff and what they might not question, things that we might question. But instead of repeat what everybody said, I might instead talk about sort of one of the first studies that perhaps used an ethnographic approach that I thought was really fascinating, but isn't actually badged as an ethnographic study, is a book by Townsend in the 60s, which is like a survey of residential institutions. And it is badged as a survey, which seems really strange now, because actually when you look at that book, it does count the number of different institutions, but it also was very much based on going and visiting care homes and doing lots of observations. There are interviews, for example, of different staff and residents in those institutions. There are photos in the book of the different types of institutions, and there's lots of commentary on the conditions of residential settings at the time. And I think that's what's sort of so fascinating about ethnographic studies, is that you can use lots of different things as data. So you might have conversations with people or formal interviews, but then you also have things like photographs and your observations and documents where you can bring artifacts in. That in itself is really fascinating. I think could be really powerful.
Brilliant. Thank you so much, everyone. So as anyone listening will be able to hear, we are a group that are deeply convinced by ethnography. And I should just say for myself, as someone coming from a clinical background, when I first even came across the idea of ethnography, it was just quite exhilarating to be able to see that you could do something where you could be so open to being surprised and do so little. It wasn't a case that you knew exactly what you were looking for. You just had a kind of inkling that there was something really important here to find out, but you couldn't quite control and design exactly how you'd find that out. And that, I think, for me, is also one of the things that really draws me to the method, is that the element of surprise, the element of being surprised throughout ethnographic research. But the reason why we've come together as a group, both in this context and earlier in the year, is because, as well as being a method that has unique ways of creating knowledge within health and social care, ethnography also throws up some quite specific questions in terms of both ethics, so actually how we do the research ethically, but also, and kind of partly relating and partly not relating, governance and some of the approvals that one needs. And so maybe just to kind of get us started on this, maybe if I come to you, Kathy, could you share an experience that you've had, either good or difficult, about the ethical and governance processes towards getting started with a piece of ethnographic work?
Yeah, I mean, it's certainly changed a lot over the years, and I reflect that actually there wasn't very much ethical governance in the 80s, late 80s, early 90s, and you could often go into spaces, and I look back on that now and feel a bit uncomfortable actually that there were no kind of controls or regulations about that. But one of the most recent examples is from a study that's currently ongoing, and in fact one of the field workers is out now collecting data today, is a project about emergency department waiting lists. So I'm back on my waiting list topic, but I'm wanting to observe in the waiting room areas and the other areas that patients might travel through while they're still officially part of the emergency department's responsibility. And the way that a classic ethnographer might describe doing that and the ethical process would be that you would get permission from the people running the organisation to lurk in the corners and watch what's going on, and you might try some kind of blanket way of alerting people to the fact that there was somebody in the room taking notes, so you wouldn't sort of hide behind a mirror. And then if you actually wanted to talk to people, you would approach them much as market researchers do on the street, and just say, hello, my name is, I'd quite like to talk to you about what's going on. But we fell into all sorts of problems with proposing doing those sorts of approaches, because there is a concern that if you get a doctor to ask a patient to be involved in a study, if you delegate that asking, that patients will feel coerced. They will feel that their doctor might not give them the right care because they've said no or whatever. So you can't do that. But equally, the researcher is seen as having a vested interest in getting people to say yes, so may, incentivise in some way that I don't really understand people to take part, and therefore also be at risk of coercing or forcing people to take part. So we had this very interesting interaction with an ethics committee who I really think were doing their best within the rules that they have. You know, they were lovely people. They took the job of ethical review incredibly seriously. But the upshot of asking to do a study that was about observing in emergency departments, which are semi-public areas that you could walk into and access relatively easily, and which are currently also being filmed for television reality shows, was that we could do the thing of having posters up warning the public in the general waiting area that there was a researcher, and have a plan for if somebody said, I don't want the researcher to watch me or look at me. So that was all fine. But they said, in terms of approaching people to ask if we could, for example, shadow their journey through the department or talk to them, brackets, interview them, we had to have what I ended up calling the bingo card, because we were really interested in health inequalities. So I knew exactly the kinds of people that I would be looking out for, and I wanted to look out for people that appeared to be from an ethnic minority group, because we know that there are concerns about the way that our healthcare system treats people from ethnic minority groups. I was concerned about people that might look like they were homeless, because we know that they have presented issues, and the sociological work in the past suggested that they might have been treated differently. So there were a sort of list of the types of people I would be interested in, and I know what I think they look like. And of course, in this world, you may, misidentify somebody. Possibly a baroness could be wearing clothes that make her look like she's a homeless person, and that would be an interactional problem that I would have to handle as a researcher. But basically, I knew that there were the kinds of people that I would be most interested in, and I didn't want to make loads of work for the busy emergency department to do. So the ethics committee ended up asking us to use a bingo card that specified the kinds of people, so that the receptionist in the emergency department would look at the bingo card amongst all the other things that he or she had to do and say, oh yes, the person in front of me looks like they might be a black person. What I'm now going to do is give them a slip of paper asking them if they're interested in being part of the study, and they'll take that piece of paper away, they'll sit down and read it, and when they've read it, they'll come back to me at the reception desk and say, oh yes, I'm really keen to be involved in this piece of research. Could you locate the researcher for me and I'll have a chat with them? And I said that this wasn't going to work, and lo and behold, we were getting terrible, terrible response rates, because nobody, you can watch people. They take the piece of paper and sit on it, they stuff it in a bag, they crumple it up and put it in the bin. It just was never going to work. Anyway, so we went back to the ethics committee and said, would it be all right if we just approach people like you get approached by market researchers on the street? I mean, I actually wrote a script that said, we will say exactly these things, and we will give people, a period of 10, 15 minutes to think about it. We'll go and stand further away from them, and then we'll come back and say, have I given you enough time to think about it? Have you got any questions? Would you mind talking to me? And people say yes. When I've made those kinds of approaches, I've never had someone say no. And I don't think it is really because I'm a big, scary researcher. I think it's because people want to tell you their story. And when they're waiting 7 hours, 13 hours in an emergency department, they love somebody to talk to. They want to tell you all about their experience. So I feel like the ethics committee worried about this coercion of the approach and made us do something that I knew was wrong, but I had to sort of go along with it to try and show them that I was compliant. And then when it didn't work, they let me change it back to the sort of thing that I would have done anyway. Anyway, so that's my latest version of troubles with ethics.
Thank you, Kathy. And I know that in this group, and including myself, we have got a lot of different stories. Some of them actually really positive. It should be said, like it's not uniquely difficult or universally difficult to go through these processes, but yeah, there are plenty of stories that could be told. I'm going to go on to the next part now and ask Nikki, maybe if I come to you, could you tell us a little bit about what happened early this year, kind of how the ethics and ethnography workshop and then observatory came about, and then we'll share a bit about what happened that day after.
Yeah, thanks, Stephen. So we've been here at the University of Leicester, we've been running a summer school on ethnography for healthcare improvement for a number of years. And I think just having people attend the summer school, it just felt like this sense of deja vu. Every summer, people would be coming and describing the nightmares that they were encountering with ethics. And I have to say, Stephen was the one who sort of came at the end of the summer school before last and just said, there must be something we can do at a collective level to actually do something about this. And I knew of other people who were, again, working in this field and had published. And so I think at that point, I thought, at that early point, I thought, well, maybe we'll write a paper about this. So I approached people who had quite a long established track record. And one of those was Kathy. And just to sort of say, can we just have some impetus around a number of us getting together to see if we can address this? And Kathy can come in here, but, she pretty much said, let's not go down a paper route, because, again, it could get published, but actually we need something more high profile, and actually we just need to influence the process in some way, and we need to galvanize and get people behind this. So yeah, Kathy, do you want to come in?
Yeah, so I think that was the impetus for it, and you kind of just nudged me to make an idea that I'd been thinking about happen, and then we went round a larger group of like-minded colleagues and put together that amazing programme for a symposium, which we were lucky enough to host here in Oxford.
And I think our idea behind it was that we would have a symposium that we would bring together funders, researchers, people working in ethics and governance as well, and we'd sort of bring that all together to actually surface what are the issues, and that we would make that open to the public. And we used some of our money from the summer school, and Kathy used some of her money from her
Senior Investigator Award. Must mention the NIHR there, otherwise they'll never let me do an ethnography again.
So it was wonderful. We were able to use those funds and to make the symposium free. So it was great. We had great attendance. But then a smaller group of us the following day then sort of buried ourselves away to try and think, okay, we've heard all of people's experiences, what can we do? And that was the point that we actually came up with the idea of forming an ethics and ethnography observatory. And the observatory was triggered by, we were in Green Templeton with the beautiful observatory there. So that was part of it. But we thought we would just be able to then hopefully get some momentum within that observatory for work moving forward.
Brilliant. Thank you so much. And it was just personally, it was such a great thing to come to. And I think partly having myself, I went through a sort of 7-month quite discouraging, let's say that process through the ethical approval process. But I think actually coming to there, not to just have a collective moan and not to just kind of say, isn't it awful? Aren't we misunderstood? But actually to say, okay, look, let's come in good faith to believe that everyone is trying to do a good job, hopefully quite an ethnographic way of doing it. Everyone's ultimately got sensible reasons for why everything plays out as it does. Let's try and understand a bit more about the logics and the kind of competing practices that are going on under the bonnet of this thing that we all experience when we go through the process, but to hear it from a few different points of view, and it was fantastic at doing that. And so I think maybe just to come around each of you now, it'd be great to just hear about something that resonated with you or surprised you or stuck with you, or kind of just really anything that day and thinking about ethics and ethnography. Yeah. So maybe if I come to you first, Fawn, would you mind kicking off?
Absolutely. I think one of the things that came up time and time again in the discussions throughout the day was this sort of tension between having ethical approval and all the hoops you have to jump through and the way you have to write your ethics applications, but then actually taking those principles and making them work in the field. And particularly, so perhaps not completely uniquely, but perhaps what's a little bit different to ethnographic approaches to data collection is that they involve lots of people and you being present in a field. So there's a real relational aspect to the way that you collect data. And sometimes there can be a tension between what we think to be good practice, but then making it work in that situation. So, for example, we often lift procedures that we think are good practice in other forms of data collection. So one example that I can give you is thinking about having written consent and how this might not work particularly well in ethnographic research. I know when I did my PhD study, one of the things that the Social Care Research Ethics Committee asked for was that I could have sort of verbal consent from some people, but if I wanted to shadow staff, if I was just present in the setting, I didn't need written consent. But if I wanted to shadow staff for a part of their shift, then they would like me to get written consent. And I can see some logic in this, but to be honest, it didn't really work in that setting, particularly where some care home staff might be fearful or sort of nervous because of the constant scrutiny that care home staff often face in the media and from the public. There's a real sort of fear and mistrust of how are you going to use my data, how are you going to portray me, and adding written consent into this didn't seem to be helpful. So there might be circumstances where it is helpful, but it wasn't particularly helpful here. Often in ethnographic research, it's very much more how do we build relationships with the people, sometimes the gatekeepers, but also the participants of our study, in a way that people do trust you and feel that they know what your intentions are and that they can almost be themselves around you. We hear that sort of like letting your hair down type phrase when we talk about ethnographic research. Yeah, I think that's something that's quite different about ethnographic research. It was something that came up during the day.
And that idea there, just about how that which you need to do to get ethics it's such a weird phrase, isn't it? Like to get ethics, and what it is to like act ethically. Yeah, they're not completely different, but they you know, I was talking to a colleague actually earlier today about that they're just at the start of their process, and there's so much focus on this whole thing about like when you intervene or when you don't intervene, and there's so much like just like they've got clinical background as well, so what would happen if this, what would happen if that, and I spent ages like to and fro kind of about this, both kind of methodologically, the so-called Hawthorne effect, which probably doesn't really make sense compared to its original context, and all of this, but also like when it happened, it was so not like the nuclear button. It was like a couple of times I had to do something and I quietly did it and then we got on with stuff. Whereas there's a whole bunch of other ethical stuff that I never really, like, I couldn't have predicted, but that really did take quite a lot of soul searching, and I really needed the people around me to, like, who are experienced, to like chew it over and be like, what do I do here? Because this is something specific to ethnography. This wouldn't have happened otherwise. But it wasn't anything that came up through the kind of ethical approval process. And so, yeah, I feel like that's really important.
And it's really situational as well. It's, you know, it evolves. And I think the thing about the ethics process is that they're so front loaded, you know, exactly, you know, you, Stephen, have to think about what it is you might encounter and what you might do. And I had no idea on the study I was doing of ambulance crews that one night I would be, you know, in the early hours of the late evening, early hours of the morning, I would be being a drip stand on a bit of parkland. Now, I'm not meant to touch any clinical equipment because I have no clinical training, but I was going out with a single crew in an ambulance car, and they said to me, would you mind, because it would just make my life much easier, because I'll need to hold a torch because it's dark here on this bit of parkland. And I was like, yeah, of course, because, you know, if you're a passing citizen, you would do that. And I knew that it was safe. I knew it wasn't beyond my competency, but the idea that I would have to preload that into the ethics and say, if I'm asked to be a drip stand, I will say no because I'm only a sociologist, and I will let the person not have a functioning drip, like, just why would you do that? But it is this crazy process that asks you to do all of that up front with no real idea of what actually is going to unfold in a human interactional group environment.
I think it does come back to that relational thing, like we are people working with other people. And the example I can give is that when I was doing my ethnography in a care home setting, I was allowed to do certain things like give out meals and give out drinks and sit and talk to residents, like, get involved. But I wasn't doing any care related tasks, although I've done care work in the past. I wasn't there as a carer. But sometimes people would say, would you mind keeping an eye on this resident while they're asleep? And I'd say, well, I can't enter their bedroom, but their door's propped open, so I can stand here, but when they wake up I'll have to get you to help them. And you feel a little bit awful, like you think, I'm not trying to, what does that do for your relationship with the participants? You think, but you have to be upfront and try and maintain those boundaries in a way that feels sort of ethical, aligns with your what the ethics committee have asked you to do, but ethical, that aligns with your own values of what it is to sort of help other people and be a person with other people.
And I think it's also something to do with a lack of understanding of what the nature of ethnographic research is in institutional context, where research is a clinical trial. And so the ethics that we have to address, or the questions that the ethics committees are looking for, I think they're more inclined to think of our research as intervention of some sort, including questions, my sort of constant gripe. I know I'm not meant to mourn, by the way. When you're completing the IRIS form, is questions that have absolutely nothing to do with ethnographic research, that you have to tick a box. Are you going to be exposing people to radiation? Are you, I am actually observing. I've already said I'm observing. It's all those kind of things. But I think what Fawn is pointing to, in my view, it also relates to that idea. What is ethnographic research in the eyes of ethics committees, and what does it actually do? And I don't think they understand that well enough to be able to foresee, to ask the right questions of researchers going into that space, into those spaces of care.
Maybe if I can come to Kathy next on just your learning from the day, and perhaps particularly around what we heard from Jonathan Montgomery, who's involved in setting up the HRA. Just, what was it about that, his talk, that you took away?
Yeah, so I've known Jonathan for a long time, but he was chair of the HRA from, I think, 2012 to 19. And so he very kindly agreed to come to the day and talk to us. And I think what he really made concrete for me was just how much we are being subjected to a process that is not remotely about us and what we do. He placed everything in the historical context of great harms that had been done to people that had been experimented on, people that had been exposed to radiation and didn't understand what the implications of that might be. And he gave us some really interesting sort of challenges, really, by presenting the idea that ethics committees have been set up to address malfeasance, which is stopping evil, and sometimes the boundary of that and non-feasance, stopping people doing good, gets blurred. So I found that quite illuminating. And then he also talked about the sort of disproportionateness of the requirements for things that are essentially low risk, which is what the kinds of things that we do, and asked us to think about what would make us trustworthy, what things could we do that would reassure a research ethics committee, the people reading the IRAS form, that we were not going to be doing anything in a space that would be risky, compromise safety or safeguarding, and all of those sorts of things. And some of that, I think, is about us as a community. So one of the nice things about the observatory is I'm hoping that we'll use it as a network to support each other, to share advice and tips about doing ethnography in ethical ways, but also that we grow the next generation to think about what are the things that matter. So Fawn's point about that relational aspect and the situational aspect of ethics, that it's not really about what you put down on the form or what you can get away with when you initiate that process. It's about what you do throughout, and thinking about how would I behave ethically. So I'm not going to reveal the real names of people that I've observed or spoken to. I'm not going to be careless with the data and the analysis in ways that might reveal their identities. I'm going to pay attention as a non-clinical person to the kind of rules of citizen engagement, which is if somebody is distressed in front of me, I will behave in a humane and responsible way. If somebody has some kind of medical episode in front of me, I will find somebody that can deal with that. If I see something that concerns me, that makes me think there might be abuse or something criminal happening, I will, within the limits of what I've discussed with the research team and in the design of the research, find a way of alerting the appropriate parties to that, all with the idea that I'm trying to do good, that the work I'm trying to do is trying to make a positive difference in the world, and I'm trying to avoid doing evil. So I'm not exposing people to radiation or nasty things. I'm doing something that hopefully will generate learning for good. And it was really refreshing actually to sort of have Jonathan say, it's not that we're deliberately targeting you, it's just that actually in the scheme of things, the clinical trials is such a huge issue, and some of the things that have gone wrong in the past have been so enormous, you know, so there's stuff that is at such a high level. And he's like, you know what, you're just like the ants of the research world, but you're just getting trodden on by us because we've got a process and it's just not comfortable for you.
Yes. Yeah, thanks, Kathy. And that kind of final point of just, there have been times, I think, in the middle of some of the 7 months of waiting and reapplying and getting sort of unfavourable reviews and so on, where I did just think, what are you really scared of here? Like, what is the worst that can happen? But the answer, I guess, is that there are bad things that can happen, both in ethnography, but also when you look at health research more generally, there's all that background that Jonathan was speaking to of like, no, there's a real reason, like really, really quite terrifying reasons actually for why these processes have to be pretty watertight. And now it's a way of trusting that had its own logic and finding a way to work within that logic with what we're doing. Nikki, can I come to you next and about what's resonating with you after the workshop?
Well, I think just following on from that point, I think the whole thing around the logics of this, I think it's so problematic because in a way the forms, what was really interesting was after the observatory, one of the tasks that a small subgroup of us, Fawn was part of it as well, we went away and looked at the RS form, tried to map how much of it felt appropriate, but also what was missing. So I think it diverts attention to perhaps those processes that actually, in a way, could gloss over what is really significant in terms of judging. So coming back to Kathy's point about what Jonathan said, you know, how do we actually enable people to trust us through what we write about how we're going to be? And the forms do not allow us to do that. So I think we're in a bit of a double whammy of sort of writing stuff that doesn't feel important, but also the stuff that actually is about relational ethics is actually not present. And I think one of the other things that really resonated from the day was this idea that because the process is so tortuous, that actually it's shaping the sort of work that we do, and that actually for some people it's too much and they would choose. And I've certainly been, I can remember, I think it potentially was at a medical sociology conference, where actually I was in a small group where we were talking about some ethnographic work, and it was around COVID, so things were even more heightened. But people were saying, oh no, you don't want to go down that. It's just too tortuous, too complicated. Choose a different design. And I think that's really sad if that's the way that, almost research design is being shaped, particularly when we think about those populations that perhaps need advocacy or need people to actually go in and see how things are actually working in practice, and sort of those that, almost that sort of sign of vulnerability, that often ethnography is incredibly powerful at actually surfacing some of those power relationships and what goes on. And that's worrying if that's being designed out. So that really came across for me at the symposium. And we had a very powerful group of public and charitable sectors who'd been involved in some of our work. And certainly one of the people presenting was somebody from the Bliss charity who's been supporting one of my projects, looking at preterm birth and the optimization pathway. And they had worked very carefully with us in the ethics process to actually give their support, both from a parent panel, but also from the charity, to say this ethnographic work is absolutely necessary, that no other method is going to get at what we want to hear. And actually the risk of hearing identifiable patient information is, marginal comparative, given it's going to be anonymized and we're not actually attending to it, is marginal comparative to what knowledge we're going to gain. And actually that made our transit through ethics quite easy. But again, it was just very interesting, that idea of almost trying to know what the rules of the game are, how we can work with this. And I think working with communities, public and patients is a way that we can actually try and support that process.
Yeah, thank you. And there is that horrible overlap of anxieties, isn't it? If ethnography kind of multiplies anxieties of people who are involved in research governance, then also adding in communities where there's more anxiety about them because there's an issue with giving consent, or because it's a community that's marginalized, or because it's just a field where there's known to be, you might well see some stuff that is troublesome. That might be the very reason why you need to do the ethnography and go there, is because there's some trouble there. But the kind of multiplication of those anxieties, whether real or just perceived by researchers, that might stop people going there in the first place, is, that's a problem. Shadreck, how about you? Something from the day that stuck with you?
I think in keeping with Nikki's point about sort of the difficulties of accessing ethics, or maybe going through ethics processes. There was a long conversation that we had around the Confidentiality Advisory Group, CAG for short, which is, as I learned later, is not a new thing in qualitative research, or was as an instrument for assessing for addressing concerns about confidentiality. It's been there for a long time, but I think it's only emerged in the recent past that the ethnographers applying for ethics review have been approached or have been advised they won't get the review or the clearance to do research until they have done this. Now, for those that might not know, Confidentiality Advisory Group is an independent body that advises the HRA and the Secretary of State for Health on non-research use of patient data. So it's about managing those things. Now, it's a very important part in the current economic and research context that we're in to have these measures in place. However, it's when they're applied to ethnographic research, in which the idea that we are going to be in confidential spaces observing or confidential conversations that we therefore may take with us or use as data, and that might become problematic for the people that we observe. This was sort of raised as a big issue. What really stood out for me was how many of us first of all, had just recently been subject to that process. And then we knew very little about what was expected, what the process looked like, what to do to get the clearance itself, but also what CAG actually did, because we all thought there wasn't much that it added to what we were doing beyond what we already provided in the existing framework through IRAS. I think everybody felt it was a burden. It was an unnecessary addition to the process because we didn't collect confidential data. We observed practices and conversations, but we never wrote people's names or addresses or anything like that. So I think that was a big thing for me that still stands out today, sort of pointing to the need for us to sort of have more conversations, I suppose, around how what this process means for ethnographic research going forward, but also how the HRA and the Confidentiality Advisory Group, I think, works with ethnographers to make sure that everybody understands what their roles are, and how do we work together to make sure we address those concerns about confidentiality as they relate to ethnographic research. Because I think the current IRA system addresses those issues really well for ethnographic research. But when we add the CAG on it, it just becomes a little bit more complicated, leading to, to what Nikki was pointing to there, the sort of anxiety or the fear that we might not want to do that anymore in that process. So yeah, for me, that's what resonates for me going forward.
Just for any listeners not sort of used to some of these terms, IRAS is the form that in the UK NHS ethics system one fills in. Maybe finally then, just kind of coming in then from this theoretical level of what some of the problems are, which I think we've discussed and I certainly feel are clearer off the back of the workshop and that kind of in-person meeting in the observatory. But like, how do we actually now move forward? Like where are we going? What do we need to do to actually make this better for everybody, for regulatory and ethical boards, for ethnographers and researchers, and for the patients and potential participants in studies? What comes next? Kathy, I'll come to you first.
So I think we've got a sort of hit list, a small group of people and a hit list of things that we want to achieve. And I think at the top of it kind of says no moaning, because we've done the moaning and we've done the sharing of it was really difficult when I tried to do whatever. I think one part that I want to take forward is the conversation with the HRA, where we engage with them in a spirit of kind of quality improvement. How can we share our knowledge? How can we do the thing that Jonathan was asking us? How can we reassure people that we are trustworthy and that we're not going to do terrible things? And maybe to get them to think a little bit about the situational and relational ethics, so that we can adapt processes so that there are things. So, in recent years, they've added on the box that says, is your project qualitative? That wasn't there at the beginning of the IRS form. And now you can tick that and it filters out a number of questions that you shouldn't have to then fill in. And I sort of feel we might be coming to a point where we have an is it ethnography? Because there's lots of qualitative interview studies that I think have a very particular ethical set of procedures and processes. But I think ethnography, there might be particular things where you could ask people to specify some of the things that, all of us have said today that we think should be thought about, so that you can reassure yourself. And I suppose the other thing that I would like to put on the agenda for HRA and for all of us is the looking after our researchers. And I'm really conscious of that now that I feel like I'm a bit kind of long in the tooth with all of this stuff, that there's a crop of early career researchers coming through. Many of them were educated and trained during COVID. And so their experience has been of virtual research and things. And it really strikes me how embodied ethnography is and the ethical responsibilities we have to early career researchers, that we're saying, we'd like you to just go out and hang around in a care home, and you're going to see things that might be distressing or might remind you of things that have happened to your family members. How are we going to look after that? And it's sort of like those gaps in the processes. I think we could have better ethics processes for ethnography that would address what we really do, and also help us all as researchers, as research leads, and as people that are opening doors to let researchers in, behave ethically going forward.
I think this is a little bit about what's next, but I think what struck me as people were answering the previous question was that there are already lots of things that researchers can do right now to try and convince research ethics committees that they can trust us. So, for example, we've got a really good community of ethnographic researchers, and that was so evident at the event because so many people turned up and wanted to engage with this. And I always sort of struck by how helpful other researchers can be. When I was getting approval for my PhD study, although we've got lots of ethnography expertise at University of Leicester, we did very few care home studies at the time, so I was able to reach out to other researchers who had done ethnographic studies in care settings, and they were so helpful in terms of talking through the issues and helping me to think about how I'd write about those in an ethics application. But I think also, I think perhaps you, Kathy, talked earlier about showing that you're aware of some of the issues and just addressing them head on in your ethics applications. Perhaps encouraging researchers to reference other well-established ways of doing research. So that might be particular approaches to gathering consent, or if there are reports related to your topic. So in my instance, that might be reports related to research in care homes or including people who lack capacity. All those things are going to help reassure an ethics committee that you've really thought about this and that you're not going off on a whim because you think this is a good idea, that this is a well tried and tested method for doing something. And then there are two more that we talked about. So people talked about working with people and communities that your research might affect. So if you can discuss some of these issues and say, do you think that this method of data collection would work? What do you think the pitfalls are? How can we overcome some of them? To show the ethics committee that you've had those discussions and really tried to meaningfully engage with people and to make changes based on what they've said. That will reassure them. And then just sort of related to the CAG issue, to be sort of head on and say, yes, we might overhear things. It is likely in a health and social care setting, we might come across personal data and overhear things, but we won't record them and we won't reproduce them. So I think I think there are lots of things we can do now, although there is still work needed to be done.
Brilliant. Thanks, Fawn. Over to you, Shadreck.
Yeah, I was going to make the point that Fawn just made towards the end there about getting ready, about ways of responding to CAG. But I think there's another point, another conversation we had, which was about, I think, supporting and engaging with research ethics committees themselves to get a better grasp of what ethnography is, what ethnographic data actually looks like and what it does not look like, what we do and what we don't in practice. And I think that way it will help sort of ease these tensions. And so we may have to find ways of maybe engaging more or inviting them to some of our events to be present, to see what we're doing, what the study or research findings are and what they look like in practice, and giving them more ideas about the methodological processes of what we encountered in those places. Because I know that research ethics committees sometimes can be there are volunteers who actually sit on these committees, and some of them might not really fully understand the different contexts in which research actually takes place. And so it might be useful to engage with them. I think we had a long conversation around how we involve or engage with them going forward. And I think it's really important to for us to keep that going forward, which I'm grateful Kathy has got that on her top agenda, I think.
Brilliant. Nikki.
Yeah, I mean, I suppose just to bring some of that together, I think what's really interesting, we had lots of circular conversations at our sort of post-observatory about whether there's a way we can actually specify what good ethnography looks like. And in the end, we backed away from that, because I think, in a way, it's a bit like what we're saying of the fluidity of going into practice. You don't know what good is going to look like. That's situational. And that's the whole thing about situational ethics and relational based ethics. So I think in a way, what we're trying to navigate is building relationships across communities, both within the ethnographic community, but also with wider groups, and actually so that people do understand what our work looks like, but also hopefully the observatory can act as a sort of, a group that is there to support both people working within it, but people who are also want to learn more about it. And maybe we can describe the different shapes of ethnography, give some people some idea of what different flavours look like rather than a prescriptive way.
Well, thank you all so much for coming on the podcast today, and more than that, actually, just for the work each of you are doing in supporting ethnography to grow, to flourish, to happen more ethically. I think it's not about, as is clear from the discussion, trying to make it kind of just easy. It's the difficulty is inherent, but it's to deal with the real difficulty, the real kind of the real ethical bits, and to try and take away some of the things that use up a lot of time without perhaps doing much good out there in the world. So thank you for your leadership and ongoing efforts in that. And thank you everybody for listening today to the podcast. We'll be back with another episode soon.